All right. Looks like we're ready to start. Good morning, everyone. Welcome to GI Grand Rounds. It's really a pleasure to introduce Dr. Suresh Chari, coming to us from Mayo Clinic. He is truly a luminary in the world of pancreatology, and I'll give you a little bit of his background. He's a native of India and had his undergraduate medical degree, which is an MD equivalent, at University of Pune, and then did further training in India, including a GI fellowship at University of Delhi. Spent a little bit of time in Germany at University Hospital of Heidelberg at Mannheim as an Alexander von Humboldt research fellow, and then redid all of his training, it seems, in the United States at University of Arizona first. Redid his internal medicine training, was a chief resident there, and then a year at Mayo Clinic, Arizona, and then finished his GI fellowship at Mayo Rochester, where he's been ever since, and has risen through the ranks to be professor of medicine in the GI and Hepatology division there for many years now. He's had many leadership positions in the world of pancreatology, including president of the American Pancreatic Association, president of the International Association of Pancreatology, I think ending this year sometime. He's been chair of National Pancreas Foundation. He's been on numerous review boards for the NIH and other foundations, reviewing grants, and multiple editorial boards. He's a principal investigator of two UO1s currently. One is the Consortium for the Study of Chronic Pancreatitis, and another is focused on exocrine and endocrine pancreatitis, or pancreas in type 2 diabetes and pancreatitis in cancer. Has more than 265 original publications, dozens of book chapters, traveled all over the world and spoken everywhere, and now for the first time at Mount Sinai. His debut, and it's like Carnegie Hall for GI. So we're really pleased to welcome Dr. Chari here. He's such a world authority, so knowledgeable, and an incredibly nice man as well. Thank you so much for taking the time to speak with us this morning and meet with us.
Thanks, Bruce, for those kind words. It is indeed an honor to be here and present our work on autoimmune pancreatitis. And Chris laid the foundations very nicely with some very illustrative cases. So you can stop me anytime and ask questions. Make it easy here to make it interactive. So what I'd like to do today is introduce you to the concept of AIP as a steroid-responsive form of pancreatitis. Almost no other form of pancreatitis responds to steroids. And I believe there are two distinct diseases that are labeled autoimmune pancreatitis, and we'll compare these two distinct forms of steroid-responsive pancreatitis and provide an overview of the management of both of these diseases. So they have been labeled as type 1 and type 2 AIP, and there is some politics behind why they got labeled this way. We'll get into that if necessary. But both these diseases are characterized by pathognomonic pancreatic histopathology. This is something that you've seen case after case being diagnosed with pathology. But if you go back 10 years and look at Schlesinger, it'll tell you that the etiology of chronic pancreatitis cannot be discerned from its pathology. And this was the first form of chronic pancreatitis where you could opine on the cause of the chronic pancreatitis from looking at the pathology. So this is very unique. Both of them present with obstructive jaundice, and both of them respond to steroids. And these three features led the group to say that if one is called autoimmune, the other should be called autoimmune as well. And for sake of peace, we said, okay, let's call it type 1 and type 2. And that's how it came to be. But though these two diseases are called AIP, they are really two distinct diseases. And Bruce will understand this very clearly. If I were to call Crohn's disease type 1 IBD and ulcerative colitis type 2 IBD, I think there'll be a lot of confusion in this world.
You might go in that direction.
But that's exactly what's happening here. Two different diseases called type 1 and type 2 are causing considerable confusion. And while I'm accused of being the one who called it type 1 and type 2, unfortunately there was a reason for it, and now I believe they should be separated. Now that everybody agrees there are two different diseases, at that time nobody was willing to agree that there were two diseases. So this was an initial step to separating the two, And now that everybody agrees they're different, why not name them differently? But that's been harder to convince. So to avoid confusion, we have recently suggested that AIP be reserved for what used to be, type 1 be reserved for what we used to be called AIP, the Japanese classic description. And the term idiopathic duct-centric chronic pancreatitis is a mouthful, but so is introductional papillary mucinous neoplasm. So we do use these complex terms and use the acronyms as a shortcut to naming the diseases. But anyway, somehow name these two diseases. So when I suggested type 1 and type 2, the Japanese said, give it any name and don't call it AIP. I couldn't come up with a good name. So, and the only name there was this, and nobody would take this for a term to name it. So anyway, I'll call it IDCP and AIP, and we can see how different they are. So this is our series of 78 AIPs and 43 IDCPs. And you can look at the differences and you'll agree that these are two different diseases. The age group of AIP is 60s and IDCP is in the 30s. So there's a 30-year age gap between these two groups. The male AIP is male predominant and IDCP has no male, no gender bias. Presentation, you just saw some various presentations, but IDCP often presents with pancreatitis, whereas AIP uncommonly presents with pancreatitis. And their serum IgG4 elevation, of course, is a feature of AIP and not a feature of IDCP. And other organ involvement, which classically helps to define AIP, is absent in IDCP. And inflammatory bowel disease is found in up to 30–40% of patients with IBD, depending on how you define it, is uncommon in AIP. So basically, two different diseases called AIP, causing a lot of confusion. So both, unfortunately, are uncommon, and IDCP is even rarer than AIP, possibly because it's harder to diagnose. Both mimic other common disorders, and there's intense interest in both of these because they're both very treatable, as opposed to other forms of chronic pancreatitis where you can do ERCPs and stentings and this and that, but there's no cure for the disease. Whereas both these diseases are potentially treatable to cure. So there's intense interest in diagnosing a patient as having one of these, and in that process, a lot of misdiagnosis, overdiagnosis happens. So let's talk about AIP. AIP is part of a larger disease spectrum called IgG4-related disease. Another segue here is that at the time of naming of this disease, I strongly protested naming a disease after a biomarker. It's never a good idea to call pancreatic cancer a CA19-9 disease. So, but the Japanese felt very proud of having discovered IgG4 as a marker of the disease and insisted on calling this disease IgG4-related disease. The unfortunate part of that is that the biomarker has become equated to the disease, which is a huge mistake. And so when you see a patient with pancreatitis, and my colleagues tell me that I'm teaching my fellows something wrong. They're measuring IgG4 in the ER, and that's absolutely wrong. Because it's a rare disease, and if a patient comes to the ER with pancreatitis and measure IgG4, it's elevated, it's not IgG4-related pancreatitis. Unfortunately, the disease gets tagged to the biomarker, and then the two become one. So, but IgG4-related disease is a multi-organ disease that affects just about any organ in the body. But there are 9 organs that are more likely to be affected than any other organ, but these are the more commonly affected ones. Sclerosing silentinitis, so there is a orbital and surrounding organs that are affected. The orbit, the salivary glands, the lacrimal glands, and the orbital muscle and the tissue in there. Retroperitoneal fibrosis, interstitial nephritis, orbital cerebral lymphoma, IgG4 sclerosing cholangitis. I put autoimmune pancreatitis at the center of the universe of IgG4 disease, and that's because I'm a pancreatologist. If I were a rheumatologist, I would put silentinitis probably at the center of the universe. It's interesting to note that if you were a rheumatologist and you started with a spectrum, a group of patients with silentinitis, autoimmune pancreatitis wouldn't figure very prominently in your list. Just as silentinitis doesn't form a big part of our series. And this is an interesting observation which we have continued to pursue, because we have series from Mayo which have come from different departments which have different focus. So you have an orbital pseudolymphoma series and a series of patients with autoimmune pancreatitis, a series of patients with nephritis, and each of them has a different spectrum of disease. Why is that? If I were to take lupus and were to describe a series of 100 patients with lupus nephritis and 100 patients with lupus pleuritis, would I see a different spectrum of involvement in the two diseases? I don't think so. So why is this? And so we took a bunch of patients with head and neck IgG4 disease and compared them to pancreabiliary IgG4 disease, and indeed there was a difference. The diseases tend to cluster around the organ that is primarily involved, and if you have orbital pseudolymphoma, you're more likely to have silentinitis and very unlikely to have pancreabiliary disease. And if you have pancreabiliary disease, you're very unlikely to have orbital pseudolymphoma. So there is more to this story than meets the eye, but at this point, this is all called IgG4-related disease. There may be subsets of this that we are not aware of, but they share a lot of commonalities, and so it's worth still calling them all one disease. So there may be more subsets to be discovered here. So if you take AIP, it is the reason it's the center of the universe of IgG4-related disease is that if you took a series of patients with IgG4-related disease, at least 70% of them will have AIP. Maybe it's because it's the most well-known manifestation of IgG4 disease and has been the most longest described manifestation of IgG4 disease. Nevertheless, even today, if you took there are a series of pulmonologists describing series of IgG4 disease from Mayo. And if you look at the series, there's no gastroenterologist on the paper, but 70% of patients have AIP. So if you go around looking for IgG4-related disease, you'll predominantly find pancreabiliary disease. So it forms a fair number of cases of IgG4-related disease. They're predominantly male. So if you look at the 70%, this is the proportion of patients with these various manifestations. 70+% are male, 70+% are over the age of 50. Presentation with obstructive jaundice is in close to that percent. 70% have elevated IgG4 and 70% have other organ involvement. And all patients have diagnostic histology when available, and all patients respond to steroids. So this is in a nutshell the clinical profile of autoimmune pancreatitis. There are, however, other manifestations of the disease, which for ease of remembering is a mnemonic called HISORt, which kind of gives you the features on histology, imaging, serology, other organ involvement, response to steroid therapy. These HISORt criteria are best described for AIP, but pretty much can be described for the other organs as well. So let's look at histology. You saw some very nice pictures of histology. So diagnosis is only possible on core biopsy or resection as it needs architecture. So cytology is not adequate to make a diagnosis. It's mostly used to exclude the cancer diagnosis rather than to make a diagnosis of AIP. It's very tempting to do IgG4 stains on a smattering of cells that you get on cytology. Unfortunately, without architecture, you're very prone to make a mistake on making a diagnosis of AIP. 30% of patients with pancreatic cancer have IgG4 positive cells in their tissue. Fair number of them. 30% of cholangiocarcinomas do that. 30% of PSCs have it. So IgG4 infiltration in the tissue is not equal to IgG4 disease, and therefore cytology is not sufficient to make a diagnosis. And you saw all the cases that Chris showed had nice architecture, and there were other features that were being used to make the diagnosis, and that is the basis for the diagnosis. So as he showed, here is a core biopsy of the pancreas. So what you see here is diffuse lymphoplasmacytic infiltrate centered around this medium-sized pancreatic ducts, and it's fairly intense. So there's a very inflammatory disease, which is fairly painless. So for all those interested in understanding pain in chronic pancreatitis, this disease needs to be studied as a positive control. Is these patients have inflammation but little pain. Why? It's not clear, but it certainly is the pancreas is certainly very inflamed. Another picture of that, you can see again, and you'll see the contrast to IDCP, that this duct is intact and does not have inflammation, is not inflamed, but there is intense inflammation surrounding it. So this is that storiform whorly fibrosis that is fairly typical of this disease. It's not diagnostic of this disease, but it's fairly typical when you see it in the pancreas. The other forms of chronic pancreatitis do not have this whorly appearance. And a good pathologist can get bits of tissue and look at the bits of fibrosis that are in there and kind of have a hunch that he's dealing with with AIP. This is another example of the storiform fibrosis. Yet another example of the same. You can see the whorly appearance. Apparently, this is something that you have to see to understand what it means. The other finding that Chris had also mentioned is this intense inflammation surrounding the vein that completely spares the artery. So here is the artery, and it has very little inflammation surrounding it. Right next to it is a vein that is intensely inflamed to the point that it often completely occludes the vein. So obliterative phlebitis is something that is very peculiar to IgG4-related disease and AIP in particular. Some organs affected by IgG4 disease do not show this, but most organs do. This is another example of an artery that is spared and a vein that is close to being occluded by this intense inflammation. This inflammation, of course, stains for IgG4. So you have lymphoplasmacytic infiltrate, you have IgG4 positive cells, and you have a vein that is inflamed, but the artery is spared. So this piece of tissue might give you the diagnosis right here. Another example of an artery and vein, you can see the difference, how one is affected, the other is not. And of course, this disease is characterized by this feature of IgG4 positive plasma cells, and more than 10 per high power field is considered to be highly suggestive of the disease. Unfortunately, if you take this alone, it's not by itself diagnostic and can actually cause confusion if you take IgG4 positive cells. And one of the other problems is that you do need that number, and pancreas has been given a pass by allowing 10. Most of the organs need 30 or 50 cells per high power field. And if you take less, if you lower the diagnostic threshold to 4, you'll start making mistakes. So you do need plenty of IgG4 positive cells to make the diagnosis here. So in summary, you need dense lymphoplasmacytic infiltrate without duct destruction, diffuse fibrosis, which is storiform, obliterative phlebitis, and many IgG4 positive cells. And you need about 3 out of these 4 to be a definite diagnosis. And if you have 2 out of 4, you have a possible or a probable diagnosis of IgG4 disease. Yeah.
In response to steroids, do any or all of these changes reverse?
So we have, obviously you see patients in all, nowadays we see patients who are half treated and so on and so forth. We have biopsied and we still find enough evidence there to be able to make a diagnosis on a patient on steroids. What doesn't go away is the fibrosis. So if you have storiform fibrosis with minimal inflammation, you might think this is burnt out autoimmune. But in patients who are still symptomatic but are on steroids, we feel like you can still go ahead and biopsy them and find that the answer is there. So the other feature is we've got on the HISORt, we just in histology, we look at imaging. So there is AIP has, another brief segue here. So before AIP was recognized, and that is the mid-2000s, where were these patients and what was happening to them? So we looked back at 2,500 resections that were performed for obstructive jaundice suspected to be pancreatic cancer at major institutions like Sloan Kettering, Johns Hopkins, Mayo. We collected series that were there and looked at what proportion of these patients had AIP. And it turns out that about 2 to 3% of patients who present like pancreatic cancer and are ready to go to surgery actually have this disease. So it is uncommon. Yet, I think that for the most part, we are able to make the call. And that's because we understand these uncommon disease can still be separated from 98% of the patients who present with jaundice because they have some peculiar features. And one of them, that is the one that everybody gets, is a CT of the abdomen. So we start with CT of the abdomen to risk stratify these patients as being highly suggestive of AIP, highly suggestive of cancer, or indeterminate. And one of the things that you want to look for in the CT scan is diffuse enlargement of the pancreas with featureless borders, what is called sausage-shaped pancreas, without ductal dilatation. And on a dynamic scan, you see the pancreas that is brighter on the venous phase than it is on the arterial phase. Normally, you would see the arterial phase to be the one that is brightest. And then in this case, you see, because of inflammation, there is slow uptake of the contrast. So the venous phase is brighter than it is in the arterial phase. This patient shows you all these features and more. And so the patient has a diffusely enlarged pancreas, featureless borders, and no pancreatic duct dilatation. And this patient has multiple other organ involvement. He has retroperitoneal fibrosis. He actually has a renal lesion here, and he has a bile duct which is enhancing. So this patient makes a diagnosis simply based on this one cut. How often does this happen? This happens in about 40% of patients. So there are 40% of patients where the diagnosis can be made simply on a CT. So you were asking about when we need a biopsy for this patient. We used to biopsy these patients just because we learned how to biopsy on these patients. It's easier to biopsy on these patients because they are nice and fat and the duct is small. The risk of hitting the duct is not there. And of course, in those days, we didn't know what we were dealing with, and getting the tissue was helpful. But clearly now we know that these patients don't need a biopsy to make the diagnosis. So this is my very first patient I saw in 1999 with this diffusely enlarged pancreas, and my colleagues had done a pancreatogram, and this shows a diffusely irregular narrow pancreatic duct, which goes with this. And this is yet another one. This feature that we see here, which is a enhancing rim around the pancreas, is actually fairly useful. It's not seen in pancreatic cancer, seen in about 35% of patients with AIP. And when you have this combination, it's fairly specific for AIP. So this is a very gross example. It's funny, today we rarely make the diagnosis ourselves. They already get diagnosed. And if I put this up today, first year fellow will make the diagnosis. So this has obviously come a long way in terms of the recognition of the features. This, on the other hand, is difficult to diagnose. So this is a patient with what looks like locally unresectable pancreatic cancer. And this patient actually was in a major hospital waiting for pancreatic surgery when he decided he himself will discharge himself and come to Mayo for care. So these can look like pancreatic, and they look pretty ugly. In fact, I give talks on how to differentiate AIP from pancreatic cancer. At the end of the talk, I say all the pictures I showed you were AIP because they look completely inseparable in some cases. So this is the pancreatogram where you see this diffusely irregular narrow pancreatic duct with multiple strictures without post-stenotic dilatation. Yet another case of a stenosis here, but no post. This is something that we see in patients with AIP. Multiple strictures all through the duct, a beaded pancreatic duct, again, strongly suspicious. Another feature is this very long stricture without upstream dilatation. If you take 5 millimeters of upstream dilatation, so this looks like bigger than this for sure, but these long strictures are highly suspicious for being AIP. So let's move on to serologic abnormalities in AIP, and I've classified them based on how frequent they are. The commonly elevated ones, more than 50%, are IgG, IgE4, and IgE, present in more than 60% of patients, of which IgE4 is the most common at 75%. And then there are features that are found in 25 to 50%, which are eosinophilia, low complement, and a variety of other non-specific autoantibodies. Uncommon is elevated CRP. For a multi-organ disease, that's why I don't try to use the word systemic. The systemic features are very uncommon, like weight loss, fever, and elevated CRP are uncommon. more useful to call it multi-organ disease. But you can see that there are a number of abnormalities that can be seen. All of them have differential diagnosis. None of them is pathognomonic in themselves. So here's a problem with IgE4 and why I was very unhappy with naming it after IgE4 disease. So we did a study of 6,000 IgE4s measured at Mayo. We found that there are 5% of those were elevated, and only 10% of those had IgE4, any manifestation of IgE4 disease. So the positive predictive value of IgE4 measured without giving any thought to why you're measuring it is going to be very low. And with IgE4 related disease giving manifestations from head pain to toe pain, people are measuring it everywhere, and that's the problem. Even if you took a higher value of IgE4, twice cut off, 3 times cut off, it still does not meet pathognomonic levels. So there is no level at which you can say there's no diagnosis here except IgE4. So the sensitivity is 60 to 80%, but is not specific. The positive predictive value is low if your pretest probability is low. So measure it only if the clinical profile fits. That's why I object to this IgE4 being measured in the ER, because at that point you have not made a call that this is IgE4 disease, and if you measure it at that time. I had a patient with gallstone pancreatitis where the gallstones were removed, and they were referred to me for IgE4 or IIP because somebody had measured IgE4 and it was elevated. And I'm saying you just found the cause, you took it out, so not sure. So it's a problem. So this is the other organ involvement. This is a very gross description of the renal involvement in AIP. But imagine just having one of these. This is a patient that was referred to the renal clinic for renal failure, and the radiologist read this MRI and said, Suresh, you need to see this patient. It turned out she had steatorrhea and had been on enzymes for a couple of years, and she had an atrophic pancreas. So she had asymptomatic atrophy of her pancreas. But we biopsied one of these in a classic IgE4 related disease. So this is very important clue. So you have a swollen pancreas and a hilar stricture. That combo is just very unlikely to be anything else. So when you see these strictures in the bile duct, the setting of what looks like typical AIP, then these are likely to be sclerosing cholangitis or IgE4 related cholangiopathy. So this is a patient with a hilar stricture. This is a patient with PSC-like changes. More of these PSC-like changes. So if you have a pancreatic ductal stricture with PSC-like changes, that combo suggests that this is probably IgE4 related. This is a patient with orbital pseudolymphoma. This is a patient with retroperitoneal fibrosis. I'm showing you the most grossest examples of this, but you can see finer versions of this in cases. This is lung involvement in IgE4 disease. It's not very specific. You'll need a biopsy to be able to tell it apart from anything else, but it is not uncommon. It is one of the top 7 or 8 organs that is involved in IgE4 disease. Response to steroids is the other very striking feature of this disease. So this patient was sitting at another hospital for 6 weeks, came to me and begged me for a prescription for prednisone. He had already made that, sitting in the bed for 6 weeks, he had figured out that he had AIP. So he did get it, and in 6 weeks this thing had shrunk. This ugly looking pancreas has actually become smaller after giving steroids. This PSC-like changes have completely resolved with steroids, 12 weeks of steroids, and now looks normal. Doesn't always go away. The fibroinflammatory nature of the disease sometimes prevents the organ from returning to normal on imaging. But if you catch it early, you can actually completely reverse it radiologically, and it can actually look normal. This is that hilar stricture that resolved with 8 weeks of steroids. And this is the pancreatic duct stricture that resolved with steroids. So many of these features can resolve with steroids, and some which are because of inflammatory, the fibrotic stricture, that may not go away. So how do you make a diagnosis of this disease? Certainly diagnostic histology in an affected organ is the most useful way of making the diagnosis. So if you have a pancreas that is not amenable to biopsy, but you have, I saw a patient the other day who had bilateral submandibular gland enlargement. He himself had not noticed it, but the moment I put my hand, he said, yeah, I felt that for the past few months. So you can go after that salivary gland instead of going after the pancreas. And so there are possibly other organs that can be biopsied if you have access to them. If you have had a gallbladder taken out recently, you can look at the gallbladder and see if you can find the answer there. So sometimes patients have had a diagnostic laparoscopy and they biopsy the pancreas and come out. You can go and retrieve those biopsies and see if you can make a diagnosis there. But if you don't have histology, then a diagnostic combination of features that includes histology, imaging, serology, and other organ. We have diagnostic criteria that we have published. They're very specific. They've been applied repeatedly and work. But many people are loath to go through all the criteria to score the thing and find out, but it actually works. So how do you manage a patient who does have this disease? So when I started, I never thought I would do this in pancreatology, make a diagnosis, induce remission, and maintain remission. Nothing like that in chronic pancreatitis. But that's basically similar to other autoimmune diseases. You make a diagnosis, you induce remission, and you maintain remission. So what do steroids do? They definitely induce remission and can maintain remission, though relapses occur on low-dose steroids. So the Japanese just published a randomized controlled trial of low-dose steroids versus nothing for maintaining remission in AIP. They do show that low-dose steroids maintain remission, so their relapse rates are 25% as opposed to 50% if you didn't give them. But my concern was, what do they do with the 25% that do relapse? Because they don't seem to have a plan B. And I'm not sure why they don't reveal it, but they must have a plan B because their patients do relapse. And so my problem with this is that, elderly people, you don't want to leave them on steroids indefinitely. So I don't use long-term steroids as maintenance strategy, but can be used, as the Japanese have used it and shown to be beneficial. Though you can imagine that at 5 or 7.5 milligrams, some people will relapse. And in their experience, it's been about 25%. So immunomodulators have been used to substitute like just the steroid-sparing agents as azathioprine, mycophenolate, methotrexate. But just like in IBD, they cannot induce remission, but they can maintain it in about 50 to 60% of patients. So if you have a patient who's intolerant to steroids, it's really difficult to just take out the steroid and put azathioprine if their disease is not in remission. It will probably not go into remission because of the azathioprine. It will be maintained, but not in. So immunomodulators can be used, but in our experience, you probably won't find the right drug for months because you'll try one. Basically, our experience has been that 50 to 60% of patients you can maintain, but 40% of patients, it's not the right drug. So I have been referred patients who've been bouncing around and have untreated disease for months because they're trying to find the right steroid-sparing agent to manage their disease. If you do use azathioprine or mycophenolate, you need to use IBD doses of 2 milligrams per kilogram rather than autoimmune hepatitis doses, which don't work. So we have been interested in rituximab for a while. There was a patient who actually had autoimmune pancreatitis biopsy proven who got ophthalmic zoster on steroids, and so we could not use steroids. And at that time, we didn't know that single agent azathioprine didn't work, so we gave him 6-MP, and it didn't work. He progressed to developing liver disease and portal hypertension, and he got something in his eye. And the ophthalmologist who looked in his eye and said, whatever this guy has in his eye, the hematologist treats that with rituximab. So we went to the hematologist, said, what are you treating with rituximab? He said, well, go stain your tissue, pancreatic tissue for CD20. If it's positive, this will respond to rituximab. So we went and stained our tissue for CD20. Indeed, it was loaded with CD20 positive cells. So we gave him rituximab, and lo and behold, everything disappeared. Portal hypertension went away, everything disappeared. So this was back in 2004. And rituximab was not easy to come by, so we have been pondering around using rituximab whenever the patient has been intolerant to steroids or intolerant to immunomodulators. So that's how we started. Now we realize that it's a very good drug. It doesn't need steroids. So if you are having steroid intolerance, or if you think the patient is not going to tolerate steroids, it's a great first-line agent. And of course, if you have heavy burden of disease, it tends to be a better drug than giving steroids. So we have recently compared induction doses only of rituximab compared to induction plus maintenance. The reason for the induction only is that we did an open label trial of rituximab in AIP between MGH and Mayo, and the company would only give us induction doses. They didn't give us maintenance doses, so we were forced to treat patients with induction doses only. But we were ourselves treating with induction and maintenance, and so this is induction only, and this is induction plus maintenance, and you can see that if you get induction only, then you start to relapse around 15 months. So there's a 40% relapse rate in induction only, whereas there's one patient is supposed to have relapsed on maintenance. I don't have a personal experience of anybody relapsing on maintenance therapy as long as they're on it. So it seems to work, and it seems to certainly maintain remission as well. So it's a good agent for steroids agent and also a single agent treatment.
And this is indefinite maintenance?
Everywhere, I think the disease is probably lifelong, but relapses are fairly easy to spot and treat, so I gave it to them for about 2 years. I don't know. There are some patients who absolutely cannot come off it. I have a couple of patients that are on treatment for 10 years, but the majority of patients can come off it, and if they get a relapse, they get treated again. So. The natural history is that they can get spontaneous or drug-induced remission. It's not durable. 50% of relapse either in the pancreas or other organs. The relapses are very treatment responsive, and relapses need maintenance therapy. It's part of the IgG4-related disease. It mimics other well-known diseases in all organs, especially tumors. The diagnosis can be challenging. Correct diagnosis can prevent major surgery and is highly steroid responsive. I spent the last few minutes talking about idiopathic duct-centric pancreatitis, and the only few minutes because that's all I know about it. It's described initially as a distinct histopathologic pattern seen in idiopathic chronic pancreatitis, and it was called non-alcoholic duct-destructive pancreatitis. Subsequently, when we looked at our cases, we did see a profile that was different from AIP. And we had to make a call whether to call it an AIP variant or call it something else. We decided to call it something else because we think it was different. And so we call it idiopathic duct-centric chronic pancreatitis. And there's a reason for this complex name, but this is the classic feature, is that the duct is the center of the inflammation. The duct is destroyed by neutrophilic infiltrate, and you get microabscesses in the duct, and it's actually fairly duct-centric in its nature, and it destroys the ductal lumen. And there's intense inflammation surrounding it, which is lymphoplasmacytic, but there's also lobular neutrophilic infiltrate. There's also some storiform fibrosis, though it's more characteristic of AIP. There's also some obliterative phlebitis, which is that is more common in AIP. But these features are fairly typical, and these are more examples of the duct being. This is a microabscess inside the duct, neutrophilic infiltration. So it's characterized by lobular neutrophilic infiltrate. When severe, you can get microabscesses, intraepithelial inflammation, when severe duct destruction, and none to minimal IgG4 positive cells. And when you look at IBD, you can see that IBD can either occur prior to the AIP or simultaneous or after. And so I've seen patients who present with obstructive jaundice, and we treat them. and 6 months later they come with florid IBD. So, and then there are others who have had IBD and who develop this, so it can come either way. The treatment is steroids, and if you use the standard treatments for steroids that we use for AIP, that is 4 weeks of 40 milligrams and then taper by 5 milligrams a week in a total of 12 weeks, it goes away. And usually this 1 3-month course of steroids is enough. And one of the typical features of disease is that relapses are extremely uncommon. We have about 2 relapses in our series of about 40 plus patients. So it is uncommon. And so that's the distinction between the 2 diseases, as well as the fact that IG4 is not elevated. So it's not, this is similar to seronegative AIP. There's no other organ involvement, so it's very difficult to diagnose this condition. It could destroy the organ during healing. So I've had, so this occurs in fairly young people. So I've had a 6th grader with this disease. By a few months, the pancreas was completely destroyed and the patient was on creon. So it can destroy the organ in which that is involved. So in summary, there are 2 steroid-responsive forms of pancreatitis, AIP and IDCP. These are distinct diseases with distinct clinical profiles, serology, natural history, and pathogenesis. And I'll stop there and take questions.